progressive painless rim, unaided stainless rim. History of rim length expectancy presence. History of before B. What is the history of fever, or history of evening rise of temperature, or history of loss of weight, loss of or history of ball joint pain, or history of morning sickness, or history of neck stiffness, low back pain and breathing difficulty, no history of burning exhalation, no history of bowel and bladder disturbances.
Excuse me, instead of repeatedly saying that no history of X, no history of Y, no history of Z, you can directly say that no history of micturition, pain, at night sweats. It sounds actually more quantity. Repeatedly, if you say that no history of this, no history of this, no history of this, actually this is just repetition.
Topic of this remaining myself. So the difference with the normal is that is there any necessary to tell all the Steve
That I think he is probably doing all the presentation as he has been told. But all these negative points what I had mentioned. What is positive point in him? What is necessary? What is that he wants from the doctor? You say that he has got painless limb. Why he has come to the hospital? That we have not told. Why he has come to the hospital?
But you are
Yes.
painless.
Now it will be a painless limb. And a person who has got a short limb, the external rotation of the limb, how do you think that he will not have back pain? When he walks, he has got a short neck, the short neck will be reflected at the level of the sacroiliac joint until lumbar spine, and they will have definitely back pain. So blindly do not tell that they have no back pain. Okay. Anything you want to add from Broker?
No, sir. Excellently described, sir. That they usually have back pains. So the candidate should examine that, or instead, before ruling it out, they should examine and add it in history. Retrospectively, they can add.
Anything else you that they should add up the history? Now it is a definite history of injury 3 years ago, which was treated by indigenous doctor, and he has come a painful limp on the left hip. This is the crux of the history in this. Do you like to add anything? Because in North India, probably the history taking will be more elaborate than the South. Is it so?
No, sir, not that much actually. During the examination, I think most of the examiners actually directly go for asking the positive findings, which are relevant, instead of going and hit around the.
Fine.
Sir, it is fine. It's fine.
Please proceed.
Fast speed, solve previous surgery, trauma, history of chronic disability, history of hospital.
Doctor, I think we have finished history taking.
So yeah, doesn't have history taken. You know all exact is not medical.
Yes.
We can
General physically. Patient is.
They are telling that the patient has got pain on the right hip also. Yes, told.
now you want to add something, you can add it.
in another home or their application also is not there. Can you mention?
Then not physical examination. Moderate will build moderate in average. Not parallel, not equal, not same with the scope of the good evidence plus everything of the bilateral total good anima. No neuroglycogenous marker. No leoness actually upper limb and lower limb ratio formation.
It would appreciate if you get the relevant general examination rather than elaborate this. It's not there, that is not there. Probably you can go for the examination, you can tell your findings, then a relevant general examination can be added up.
What is it? There is no exact number logos attributes. Headlight center, headlight midnight, both shoulder at same level, both color same level. ASIS appears to be normal, hip in neutral. Knee in extension, patella facing outwards, outwards facing the wall of home set. Ankle and foot, position of his foot externally rotated. Muscle wasting is present compared to right side. Left side is muscle wasting present over the thigh and calf muscle. And there is shortening present over the left limbs. External rotation uniformity is changed.
So salient things are external rotation deformity, shortening, wasting.
Wasting present, shortening present, sir. Externally rotated, sir. ASIS at same. No exaggerated paralysis.
We see that slowly receive brain the leader or maybe
Hip examination. Left hip. Start from inspection. No exaggerated lumbar lordosis. ASIS appear at same level. No scar, no sinus, no swelling, no enlarged vein, no visible pulsation over the scarpa's triangle. Skin lesion is fungal skin lesion is present over the aspect of there is no scar swelling, side enlarged vein, visible pulsation present over the medial aspect of hip. Lateral aspect, there is obliteration of supratrochanteric annulus is obliterated, sir. GT is not prominently visualized. No swelling, scar, sinuses, enlarged veins, visible pulsation present over the lateral aspect of hip, sir. Posterior.
Are you able to see the pattern?
No, sir, not able to see, sir. Not visible, sir. Compared to right side, the supratrochanteric annulus is obliterated, sir. Posterior. Let's say parts of that. Both DSIS at the same level, no scar, swelling, abnormal mass present over the left gluteal region, muscle wasting present over the gluteal region of left side compared to right side. Gluteal fold is asymmetry.
Agreed. Now we can appreciate that extent. Gluteal fold is obliterated.
Have questions? తెలియబడుతుంది.
Start.
Anything, sir, apart from this, you will also add an inspection, sir. We usually see the patient, middle side also we have to see.
One more point I would like to add. Instead of turning patient again and again in supine, lateral, prone, can we do it like that? First, all the examination done in supine, then in lateral, then in prone. Because every time you move the patient, patient is in pain. You so told that he has come here because of the pain and ultimately you are causing more trouble to the patient. So you examine completely in supine, then lateral, then prone. That should be the sequence we follow here.
Causing minimum discomfort to the patient.
Calculation, sir. Both the ASIS level is confirmed. Same side, same ASIS at same levels.
Are they appearing at same level? Are you sure?
Yes, sir.
Because on your right side, thumb is at a higher level compared to left side, seeing from the video here.
Initially, the camera was focused from one side, but now it has come to the center. Now you can appreciate.
Both the AS line is confirmed. ASIS at same level, sir. No warmth, no tenderness over the ASIS. No warmth, no tenderness, no warmth, tenderness present over the anterior joint plates. Tenderness present over the anterior joint plates.
But I think to demonstrate. Just to, sir, if any questions arise, you can demonstrate.
Both, okay, sir. Both femoral pulse felt equally on both sides, sir. No palpable inguinal nodes present, sir. Lateral side.
Inguinal lymph nodes, they are palpable or not palpable?
Not palpable, sir.
Not palpable. Usually, normally, inguinal lymph nodes, they are palpable because they are around 1.5 centimeter.
They are not enlarged.
They are not enlarged. Basically, there is no lymph adenopathy or no enlargement.
Proceed.
We should say it's a significant shift. From the lymph nodes, inguinal lymph nodes are not engaged. So whatever lymph nodes we have to target for the
Superficial and deep inguinal. Superficial inguinal lymph nodes.
Are they aligned in any chains? They have horizontal and longitudinal chains. Do you know about that?
I will incorporate GT is proximally migrated compared to right side, sir. there is no tenderness, right trochanteric and
Just by
left trochanteric
it's possibly irritated. You have to see.
opposite side. Opposite side I will compare. After that, digital prions I will do.
The context stage itself, you must be this digital branch.
Digital prions.
Expect you to demonstrate the digital branch. So you concentrate on both subcontractor simultaneously. The concentrate to the right side, the left is little higher level.
Higher levels. No thickening, no broadening, and the surface is also.
Which is not ticket,
Sir, left side, sir.
which is not ticket.
GT, greater trochanteric.
Greater trochanter is no thickening at all.
Surface is more.
Also, there is no tenderness over the GT area, right?
There is no tenderness over the greater trochanteric.
They're all important findings which you are telling. Based on that, only you are going to the. What is your palpatory finding of the PB bone? From you are examining. Iliac part of the bone is examined by iliac crest. PB part of the bone is superior PB grammar skin. Sometimes patients may come with the fracture of the superior PB grammar, apart from the hip bone fracture. So that also should be brought out while palpating. Proceed.
Medial aspect, there is no warmth and tenderness. Posterior aspect, PSIF, posterior superior iliac spine at the same level. No tenderness, no warmth tenderness over the posterior joint line. There is no mass, palpable mass present over the gluteal region. There is no tenderness over sacroiliac joint and ischial tuberosity. Posterior.
Tell the findings.
Now, GT is proximately migrated cell. There is supratrochanteric column is complicated. There is shortening of leg. The external rotation deformity is present. Anterior joint line is
Tenderness is trochanteric and bitrochanteric also.
absent.
No, okay.
Trochanteric, bitrochanteric absent.
2B and 2B, it's the point.
Movements. Tell the movements.
So, before telling you about the movements, what will you do?
Thomas.
Say what are the mixed recovery? That has to be one stage first, then you can tell about the area of movement. Okay. Then you have to tell about the area of movement, the quality of the movement, space will be lesser. If change is present or not. Then you have to take activity and passive. This is the components you also. So what is the ready fixed deformity? Before that, can you say it's significant or not? Now what will be the
Exaggerated lumbar narcosis.
there is an exaggerated lumbar that indicates not fixed deformity.
So the flexion deformity of
If there is base is not at the same level, it indicates.
so in the lower level, we think protection deformity. If it is higher level, it is protection deformity.
Higher means correction, lower means correction. So here there is no fixed deformity. Correct. Yeah. Now you proceed that area of movement, activity, and passive.
Patient able to do active tip flexion of 0 to 60 degrees.
Before that,
Further,
you have to say about whether the patient is able to do the straight leg raising. Sometimes examiners will be interested in knowing whether it's okay, intact. So, is he able to do a straight leg raising? Yeah, but you can tell that degree is. Okay.
patient not able to do straight leg raising, sir. Patient actively do active flexion of 0 to 60 degree. Further passive flexion of 20 degree is possible in left side. After that, it is restricted associated with the pain, spasm, and this. extension 0 to 10 degree possible said sir. Protection is 0 to 30 degrees. Adduction is 0 to 20 degrees. Abduction is restricted, sir. Adduction is increased left side.
So more of action.
More of yes, sir. And external rotation is 0 to 50 degree left side. Internal rotation is restricted 0 to 10 degree only.
Can you ask the patient to demonstrate these movements?
But only knee flexion only we do passively. Other movements are only passive only. He's not able to do abduction. He's not able to do adduction. Other movements are doing only passive. Only flexion up to 0 to 60 degree only done by patient.
Ask him to do that.
Tall, I mean, with the two come the car. In the car. Passive movement up to 90 degrees. After that, not able to.
But you told it is up to 60 degree. It was way more than 60 degree.
If we do with pelvic tilt, without pelvic tilt, the patient only do 0 to 60 degree only. Ask him to do it again.
On inspection,
இந்த கால் எடுக்காம இந்த காலை மட்டும் மடலை எவ்வளவு முடியுமோ ஒரு மடை
He said, anything said not to.
support from the only
Can you demonstrate Thomas test?
Spreading my hand between the coach and the first fence. Side. My knuckle is not crossed.
Ask the patient to hold that limb. Ask the patient to hold that limb. No. Do it. Yes.
Come to this side. We will be able to see.
We can see that flexion deformity is there. It is there. It is there. FFD is there. Some degree of FFD is there. You will be able to measure it.
If you are able to see from the side.
From our side, just zoom it out. The camera
left
angle,
side,
please
you can
zoom it
see
out.
from left side.
Can you see that light is coming from opposite side there? And ask the patient to extend. Ask the patient to leave that limb. Right limb, please extend. Right. Please extend. And zoom out. Camera, please zoom out. Zoom out. Zoom out that thigh. That light is gone.
It is gone now.
Again, ask the patient to hold that limb in the same position. The camera angle steady, please. Keep it.
Yeah.
Yes, light is coming again.
You can appreciate from this side.
From left side, from left side.
That's right.
You cannot appreciate the flexion deformity from the contralateral side. You have to see the flexion deformity from this side. Come this side. Come on the left side. And increase the flexion to the opposite hip. Ask the patient to increase the flexion of right hip. Increase it. It can go way more.
Yeah.
Ask
Hold
him
it.
to hold it. And
Yeah.
can you see the flexion deformity coming?
Don't let the pelvis rotate. Stop.
Uh,
the
pa-
pelvis
pa-
stop rotating.
Passively extend it. Try to passively extend the knee if possible. See, it is not going. It is still there. It is still there. FFT is still there.
Yeah.
That's it, sir. Yes, sir. Definitely, sir. Actually,
Okay.
yes, sir. That is more extremely
Okay,
rotated.
extend. Okay, okay. Ask the patient to extend it. He is getting
Relax.
uncomfortable.
You are saying external rotation is 0 to 50 degree. Is it external rotated is accelerated and
Accelerated, sir. Exaggerated. External rotation is exaggerated. Internal rotation is reduced.
Once you are saying it is
According to the adduction movement and external rotation movement is more. Is it? Yes, sir.
so this rotation you examine in that extension or flexion attitude.
inflection? Okay.
Please demonstrate.
Yeah.
This is external rotation. Slightly exaggerated. Chalo. Internal rotation, please.
Internal rotation.
Is it possible to do?
It is not going beyond the detail.
So internal rotation is not possible because the patient has external rotation deformity. If a patient has external rotation deformity, internal rotation is not possible.
The principle is that movement opposite to deformity usually not possible.
So if you have a flexion deformity, extension is not possible. If you have the external rotation deformity, internal rotation is not possible. This is the rule of fixed deformities. Got it? Please proceed.
There is a apparent shortening is present on the side.
Proceed for measurement and special test.
Apparent measurement, sir. Right side, 108, sir. Left side, 106, sir. There is a 2 centimeter apparent shortening there in left side, sir. Two measurement, right side is 82, sir. Left side is 80, sir. Two measurement also 2 centimeter reduced on left side, sir.
So apparent shortening is equal to true shortening, correct?
Apparent and true shortening is.
So according to that, there is no fixed deformities, no coronal plane deformity. Can patient demonstrate adduction and abduction? Fix the pelvis.
Objections. Pelvis is rotated.
Adduction again.
Is ASI moving? No? Okay. Adduction. Okay.
Right side 4 centimeter, left side 2 centimeters. Base of triangle.
Shortening is supratrochanteric or infratrochanteric?
So what about the base, length of the base? Is it longer on this side or shorter? What it is?
Right side is 4 centimeters, sir. Left side is 2 centimeters.
Okay. And what about the perpendicular?
And hypotenuse.
What about the perpendicular? Is perpendicular longer this side or shorter this side?
Handstanding.
Shorter, sir. Left side shorter.
Left side shorter. In an external rotation deformity, does perpendicular length should be longer or shorter?
Longer, sir.
Longer. So how it is coming shorter? If a hip has an external rotation deformity, you told that base is shorter, like 2 centimeters shorter, and perpendicular, which we draw, it should be longer because you told it is external rotation deformity. You told na external rotation deformity is there or not? It is there. So perpendicular should be longer. Okay. What about the hypotenuse? You must have measured it.
That's ready, but can you repeat the question, sir? Can you repeat the question, sir?
Audio temperature. Can you hear me?
Proceed. Let's proceed further.
Latin, sir. Yeah, sir. Audible, sir?
You are audible. You are.
Hello? What's that? Can you explain the procedure again? Repeat that. Hello? Are you able to hear us?
Yes, yes, you are audible.
Can you repeat the question? We are asking something about
Repeat.
it. Triangle.
In external rotation deformity, as you told that that base of the Bryant triangle was shorter. Okay. What about the status of perpendicular? Is it longer, shorter? What it is? Are perpendicular on both sides are equal? Chalo, proceed further, proceed further to the test. No issues.
Lateral line crossing the greater trochanter. Greater trochanter above the lateral line. Show lateral line. Lateral. Showmaker's line contralateral. Showmaker line contralateral they will cross.
If it is crossing to the opposite side, then there has to be some deformity.
To the corner plane, then they
If there is no deformity, then how they are crossing to one particular side?
Supratrochanteric shortening is proximal migration of GT. Greater trochanter.
Why is there? This side.
Sir, this is show my reference.
Look at that side.
Show my reference.
So left side is high.
Left side is high, proximally migrated, so. So the slide cross is contralateral.
Okay. Is it okay, sir? Because the one side is elevated. The shoemaker's slide is crossing opposite side. Not in the mid side.
The next line is convergence. Left side.
Yes,
Special test, sir. Tendelberg is active Tendelberg test is not possible, sir. So I will do assisted Tendelberg test for this patient. Patient have positive findings. Tendelberg test is positive. Telescopy test negative.
Can you demonstrate the telescope?
Yes. Give on. There is no excursions.
You cannot demonstrate your telescopic by keeping the limit of it. The limit has to be adapted. Here we are seeing this in class, like so PPT taking production up to 90 degrees. If you are the 4 meters over the contact.
Discussion is not there. Sir.
Feel the trochanter. Now you have to
There is no excursion.
take a distance. Pull, push, pull, push. What is that?
There is no excursion.
Oh,
Telescopy test is negative.
yeah, I am keeping my thumb over the ASIS, keeping the 4 fingers over the trochanter. I am palpating the trochanter and pulling. Trochanter is coming away from my fingers. I am pushing. It is hitching and going. I say it is little positive for me. Telescope is something like yielding for me. You want to check. He says no telescoping. For me, there is little bit of. I have not seen the X-ray. While yielding is there, yeah, yielding is there.
Therefore, it is considered impossible. Last year side of now that academic.
800 next year. And then, you have a band and then continue. We will accept it. So the previous is. What are the three?
No, so the objection on that.
That's what I mean. That's all you find around. In the week. Then you have it made that it's not really important.
Getting worried.
Ask him to stand at the mouth of the. So.
Oh, there is a normal side.
You can observe that it is, you can observe that pressure whether is putting pressure on that. He's standing on the left side, you will appreciate more pressure on that right side. See coming in that, yeah, that means that number is positive. Okay. Sir, would you like to add anything at this stage, sir, from your side? I think there is some problem with audio. They are not able to get marks. We can hear. That's it.
Hello. Sir, are you able to hear us? Yes, over.
You're audible.
Yes. Do you want to ask any questions now?
So, what is the gate? Finally, you decided. What was the gate? Type of gate. What type of gate it was?
What is it?
Short gate.
Painless, painful.
Painless, short gate.
Painless short limb gates.
So it was painless short limb gate. Okay. And what about the Tendelberg sign?
If the Trendelenburg is positive.
You are not audible properly. Please pardon.
Affected Trendelenburg test is positive, sir.
Okay, okay, great.
Proceed. Now you can summarize.
The 55-year male.
One more thing. If this Trendelenburg sign is positive, so why gate is not Trendelenburg? Pelvis is square. Pelvis doesn't have any deformity. Pelvis has no deformity, no coronal plane deformity. So all the parameters for the Trendelenburg gate are positive. Trendelenburg sign is coming. Patient doesn't have any fixed adduction, abduction deformity. So why the gate was missing that Trendelenburg component? Was opposite side pelvis falling while he was walking, or it was getting compensated because of the short limb gait? Usually it get compensated because of the compensation is there because of the short limb gait. It is not that visible. That's why we did assisted Trendelenburg gait. Okay, proceed.
55-year old male. The history of pain over left hip toe, history of trauma. That's instructed. There is another over a period of plantation. There is a collaboration of greater rotator of the head. Externally rotated deformity with the short limb. On movement, there is restriction in protection, internal rotation, external rotation. The protection is segregated. This side. The level of the side is positive.
Restricted Trendelenburg, no?
So it is also positive. With the short thing.
And FFD, you agree for FFD?
Sir, it's only 10 degrees present on it.
Okay. So what is your tentative diagnosis?
Provisional diagnosis.
Provisional diagnosis.
With all these positive findings, so what do you think the patient has underlying pathology? We don't want exact diagnosis, but what is the underlying pathology? It's a painless limb, short with shortening, with all those no deformity, coronal plane deformity. So what do you think the underlying pathology is?
Differentials.
What is your diagnosis? Provisional diagnosis.
Anatomical diagnosis is Coxa vara.
Okay.
Coxa vara you told.
Sir,
Coxa vara you told diagnosis Coxa vara.
anatomical diagnosis. Obviously,
Provisional one diagnosis. What do you want?
But actually Coxa vara, any kind of deformity is not itself a diagnosis. Like suppose if you say cubitus varus, it is secondary to something. Genu valgum, it is secondary to something. Coxa vara, is it secondary to something or it is primary?
In the history,
Telescopy was positive.
on union neck of femur fracture, left side. All you can do. Probably this is illegal.
No, it's common to get a non-union.
Non-union neck of femur.
It is a non-union, how do you say Coxa?
stable. Fibrous possibility of fibrous.
So you can give two possibilities.
Marginated intertrochanteric femur fracture, non-linear metafemur fracture.
That's something not like.
But it's precisely.
Basically, because the trochanteric is not like yes, you can more depending. So then the trochanteric, what we call necessarily you can say like that.
But diagnosis is the non-union of the basis.
It is because of half-linear fracture. That's right.
So it's telling you that this. Another is all union, that's the
The non-union intertrochanteric.
all union. All union of the
If you're keeping diagnosis of malunited intertrochanteric fracture, how telescopy is positive? Or you're keeping it a differential, you're keeping it differential?
Are you speaking as a differential diagnosis?
Okay. You want, would you like to get his x-rays done? Whatever.
Screen is clear.
Exactly. This is three like round. One minute. Zoom. One minute. Just. Next. Yes.
So what is your diagnosis after seeing the x-ray?
So we come or femur fracture. So, so the military shows that they have release with both hip, AP view. There is a broken center knife. Decrease the neck shaft angle. There is optimal migration of GT compared to right side. LT also migrated. Third also migrated.
What else does the
Right side.
now? What has happened to the sentence line?
Sentence line is broken.
Sentence is broken. The limb
Neck shaft angle is reduced.
yes. Neck shaft angle
GT is proximally migrated.
is okay.
LT also proximally migrated.
The limb looks more extended. Yes. It's a kind of more prominent. A lot of silvers around that.
Around the intertrochanteric.
Nasal breathing. Nasal breathing. There are a lot of silvers to keep it from there. Anything else?
Is there any changes in the opposite hip?
Yes, sir. Right side is yeah.
Yes, sir.
Particular congruity is lost on the right side.
Articular
Congruity is lost. There is a cam vision over.
After seeing this X-ray, if we doubt some clinical exam, you are not done properly, what exam will you do? Right? Again, palpation of conduct. It's any tenderness, yeah, practice.
What about the obturator parameter? Does it justify any information that? Obturator parameter is size of the obturator parameter is reduced on the left hand side. What does it denote? Inverse flexion deform, right? You've got a flexion deformity, the whole pelvis will go the flexion. You will find that the operator parameter will give you narrow. What else you see in this particular X-ray? Is an X-ray pelvis including both hips, which is sheath. Yes, we should not concentrate only on the sacroiliac. Yes, what has happened to the sacroiliac? Left side is fixed. Left side sacroiliac joint, we are not able to visualize it. Not visualize. Yes. On the right hand side, we are able to see the inferior portion of the sacroiliac joint, not the superior portion. Inferior part of the sacroiliac joint can be visualized, but not the superior portion. Okay. These are the findings which you can see in this particular case. What else will you take in this particular case? What other X-ray will you take? Do CT scans. I will ask you. X-ray spines. LS spine. We would like to see the LS. We like to see the lateral view of the hip. What is that really called? You have to take a cross-table lateral view. Take a cross-table lateral view, then you will know the frog. It is not the frog leg. It is a cross-table lateral view. Then you will be able to visualize more. Example, if there is an angle, posteriorly the fracture is angulated, that can be visualized. Or the head and neck has gone into flux position. They all can be very easily visualized without taking a CT scan, a cross table lateral view table down. Yes.
So routinely, if you get an X-ray fracture like this, what other X-ray you take? The AFib itself. Normally, you can try take a fractional know about the profile of the vein, but you can take an another the transfer. So is a routine. And then you have to look for the that to give more information about that. And that is spell of the.
What would you like to do for AFib?
It's a CT, no? What for CT?
I will go over this one.
No, we are not able to hear it.
CT scan.
Yeah.
Keep it bilateral hip bilateral side.
So you have taken the CT scan for what? You are taking MRI scan for what?
For right side there is a similarly constantly is lost. So
Taking the CT scan to confirm the union, whether it's united or not united, you can very well appreciate it in the CT scan.
viability of this
Viability of the
it is assessed by
you can associate with the
MRI.
MRI.
CT scan.
So what the picture has given you further information.
That is not moving.
There is a
Gap between
Yeah, and also it goes the answer is your definitely but it is not in
it's a gap between the yes.
When some fibrosis.
Yes. Okay. Any other investigation you want to have in the patient? Yes, now it is more visible. Yeah. Coronal cuts have shown that there is a normal vein. What would you like to do for him?
I will do MRI to rule out the viability of
I assume that MRI is right and it is viable. What is his age?
55 years.
What is his problem now? The fracture is not for not and there is a deformity. There is a short release. So the next short angle is
Reduced.
almost 20 less than 80 degrees. Okay. So you have to correct all these things. What will you do? You will preserve or you will replace?
So I will preserve the headset.
Why you want to preserve?
If it is viable, gap is less than 1 centimeter. I will preserve the head. I will do some vowels. All this. Look at the country, Australia. Look at that. Sir, adequate for to evidence and giving a lot of importance for the lab of all also. The total few replacements makes sense.
Why you want to jump? As now you said you want to preserve. Why you want to do oxygen? So the head
Correction of the here was a compressive books. It's also like this rotation schedules.
So we'll do a definite job there. What did they plan? Used to have.
And he's free. I'm very
What are the single or double or what kind of? How that is interesting. What is his job? What is his job?
Watchman.
Watchman. He's only less than 65 years old. So, if we wanted an MRI to write down, we think that the fire. Most likely is a petrocandric fracture, so the most likely is viable. If you contemplate that this is a head is viable, you are trying to preserve the head by doing a valgus stroke, which is the implant because that's not stable. And will you be doing anything at the level of the non-linear? You
Bone reference.
should do bone grafting.
Vascular muscular.
Will you do osteotomy or? Make you an osteotomy. And double angle, 120 degrees of weight, and observe this below to feel the right. Right? So, as the vertical forces become horizontal and the patient weight bearing walking they may induce an osteogenesis. This will cause unity fracture, right? I don't think that anybody will put it in the left side. What is your line of management?
So our line of in this such a case of fibers non-union, in this case is that we have to actually make the neck shaft angle and union will occur. Of course, if you feel that there is a large gap and you are taking out those you can say soft tissues, then grafting, of course, you can go grafting. There are so many things. You can use implant of your choice. Just in ROCC, we are using is double angle valgus story plate. And even nowadays, there is a modification in the DHS. So again, it has a double angle plate. So there are so many methods, but we should be able to achieve normal neck shaft you can angle, and then it will lead to healing. Of course, once you open up, you can decide whether you are going for additional grafting or not. So head on CT to me seems to be viable, and there is no you can sign of any avascularity. So better would be we should preserve the patient's own head and go for alignment or short mean osteosynthesis.
Thank you so much, sir. Can we move on to the next case, short case from your side?
Yes, yes. Give me 2 minutes. Give us 2 minutes. We'll be ready.
Thank you.
एक आगे बढ़ी रे
நானே கட் பண்றோம் பண்ணவா
Can we start? Start.
Good afternoon, everyone. My patient Pratik is a 9-year-old male studying in 5th class, residing at Karnal, Haryana. And history was given by his uncle. The patient achieved complaints of bilateral bowing of legs for last 6 years. On further history,
दिख जाए उनको। खड़ा करके, अब दिखाओ।
That better नीचे बैठ के.
There is bilateral bowing of legs, which gradually progressed to the present time, and it is observed 3 years of age by the relatives. There is difficulty in climbing stairs, but patient can walk and run without pain. There is no history of any trauma, any prior surgery or prior hospitalization. Coming to birth history, the patient's father was 78 years of age and mother was 44 years of age.
78.
78 years of age and mother 44 years of age when patient was born. Both parents expired 3 years back. Patient was a twin delivery. The other twin was weighed 2.2 kg and that kid expired at 1.5 months of age. Patient's birth weight is 1.2 kg at the time of birth and was kept in ICU for 15 days.
Very low birth weight category.
Yes, sir. Yes, sir.
Twin, low birth weight, twin.
Yes, sir.
Twin. What are the positives, sir? Twins, low birth weight,
And parents'
high
age,
paternal
high
age.
paternal age.
parental age.
Yes.
Chalo. Next.
No significant family history of any deformity in parents or siblings. Now, I would like to continue with examination.
Developmental
Sir, the history was given by uncle and he could only remember that patient was able to walk by 1 year of age and patient used to call the family relatives by 1 year of age. Otherwise, development history is not very reliable in his
Okay.
case.
So why we should ask developmental history in such type of deformities? What is the significance? Why we are asking the developmental history in these cases?
Sir, genetic abnormal and syndromic patients, they have low intelligence quotient.
Proceed with the
I would like to
examination.
proceed with the examination. On general examination, patient appears disproportionately short-statured with the hands coming to the proximal thighs.
Why you are telling it is disproportionately short?
Sir, the upper trunk seems significantly longer than the lower trunk. Normally, the hand should reach the mid-thigh level, but here it reach only the proximal thigh.
So they are reaching up to mid thigh.
But
They are reaching up to mid thigh.
Okay.
Chalo. Proceed.
sir, coming to local examination.
Short stature is the only clinical finding you found. Anything on the back?
Sir, there is increased lumbar lordosis and there is deformity in
Demonstrate exaggerated lumbar lordosis. T-shirt nikal. Demonstrate. Okay. Proceed.
there is deformity at bilateral elbows and there is widening of elbow joint, wrist joint and bilateral knee joint.
Are his arms are of normal length? Are arms short and forearms long?
They look normal. Sir.
Look normal. Okay. Proceed with the local exams.
On patients, I would like to talk about the gait first.
Sir, anything you want to add? Anything you want to ask?
The observation of arm and the forearm of this pushed to side. And you can see that the lower limb can be described by the candidate. It appears that the right thigh is longer than the left thigh. We have got bilateral flexion of the flat of the upper side. Yes, Doctor, it will see.
Proceed.
Sir, the patient has a waddling gait with the bowing of both legs with increased intercondylar distance. बेटा एक बार चल के दिखाओ.
Waddling gait with
With bowing
increased
of legs
intercondylar
with increased
distance
intercondylar distance of
and
knees. And bowing of legs.
bowing of legs. What about the base of the gait? Is he walking with the
Wide
normal
base.
no, base? Yes, he's walking with the wide
Right.
base.
So,
Proceed. Proceed.
sir, on inspection, there is a bowing of bilateral knees with bowing of bilateral knees, and so there is increased lumbar lordosis. On palpation, sir, there is no joint line.
No, no, no. Wait. Bowing of legs, you told in coronal. What about the sagittal alignment of the knees?
Sir, there
Are
is
they normal?
Sir, there is flexion deformity in bilateral knees.
Flexion deformities. Can you demonstrate how to check for flexion deformities of the knee?
Yes, sir.
Demonstrate flexion deformity at knee.
Flexion deformity at hip also. So I would like to make the patient sit and check on the side of the table.
Do it.
I cannot
Full
extend. further.
extension is not possible.
Yes, sir.
So what is the value? How much it is?
Sir, on left side, it's 30 degree and right side is 25 degree.
More or less equal. Equal bilateral flexion deformities. Okay. What about the patella? Would you like to comment on patella? Make patient stand because you cannot see arms.
How much is the deformity of the right knee and the left? How much is the flexion deformity?
How much is the flexion deformity of
Sir,
right?
flexion deformity in right knee is 25 degree and left knee is 30 degree, sir.
Okay.
Sir, the patella is facing forward in the right knee and also in the left knee and forward and downwards. Sir.
Downwards.
Yes, sir.
That's important. Next.
Sir, on palpation, there is no local rise in temperature, no joint line tenderness. Sir, there is metaphyseal widening at knee at both the
Metaphyseal widening at
at
knee.
at both the
No, knee is of distal femur and proximal tibia.
distal
Where
femur.
did you find the
Sir,
widening?
So the distal thigh and proximal leg.
So you are saying that distal femur is widened and
Widened.
proximal tibia is widened.
Yes, sir.
They are widened on both the sides.
Both sides,
Bilateral.
bilaterally, sir.
Any
So
bump, swelling?
there are bony prominences on bilateral medial femoral condyles. The both fibular head are prominent and bilaterally malleoli are prominent.
So you are
Palpation.
finding multiple bony outgrowths or
outgrowth,
swellings.
swellings, yes, sir.
Okay,
Uh,
proceed further.
Now coming to measurement, sir, the patient's upper
Movement.
limb,
Look, feel, move, measure, move. Movements.
sir, on movement, there is fixed flex.
It is normal.
Sir,
Other-
there is,
Other joints also.
there
In
is,
such a case, you must examine each and every joint.
yes, sir.
Broad. At least examine.
Sir, there is fixed flexion deformity at bilateral hip joint, sir. Sir,
What is happening when kid is sitting?
sir, there is increased kyphotic deformity.
Side se jana. What is happening when kid is sitting?
There is increased
Lumbar
kyphosis.
lordosis is going away.
Yes, sir. Yes, sir.
Lumbar lordosis is gone.
Hmm.
So thoracic kyphosis is a natural curve. What about your primary deformity?
Sir, primary deformity is abolished on sitting, sir.
So
It disappears
is
on
the-
sitting.
So on sitting, your deformity is vanishing.
Yes, sir.
What does this signifies?
It signifies that our deformity is on the femoral side.
Why?
Sir, because on flexion of the knee, the effect of femoral part is gone. So
Femoral part is gone.
yeah, now we can only see the tibial deformity, and there is no
What
Well,
happens?
deformity.
What is the change in articulation in that happens in femur, which is not there in extension?
sir, the on
In flexion, where does the tibia articulate?
sorry, the proximal femoral condyles.
Is there anything called proximal femoral condyles?
Posterior condyles. Posterior condyles.
So
Sorry.
tibia articulates with posterior
Posterior
femoral
condyle.
condyles in
Yes.
flexion.
Inflection.
So this is leading to negating the coronal plane deformity
Yes,
because
sir.
articulation right now is happening in sagittal plane.
Sagittal plane, yes.
And one more thing it signifies, deformity is in tibia or femur?
Sir, femur. In this case, it's in femur.
It is in femur.
Yes, sir.
So if it is still persist in even in flexion, then it is in tibia.
In tibia.
Proceed.
Sir, on measurement, ASIS to medial
Sir.
malleolus.
Do you like to add anything? Ask any questions, sir?
We will be interested to know what is the deformity at the level of the hip, because on sitting, the lumbar lordosis is exact lumbar lordosis is severe. I think got a flexion deformity at the level of the hip.
Yes, sir, there is bilateral flexion deformity at hip joint.
Demonstrate. So what is this test called?
Prone position.
So why you are doing this test? So you are doing this test because you are suspecting bilateral
I
deformity.
did Thomas test first, but then I found bilateral deformities. Staley's test is better in case of bilateral deformity.
So how much flexion deformity is there?
Sir, on right side is 20° and left side is.
So you are not able to extend beyond that. Huh? So wait. Don't do it like that. The pelvis might move.
Yes.
Fix the pelvis. Fix the pelvis is one hand. Try to extend. Yes, that's it. This is the deformity in on left side. On the right. Okay. So what is the value of flexion deformity on right and left side?
Sir, right is 20°, left is 25°.
Okay. Focus on knees.
Sir, on measurement, the
Movement.
Zipfist
Movement.
on movement. Sir, knees, there is fixed flexion deformity in bilateral knee. Right is 20 degree, left is around 30 degree. So there is no extension possible. Sir, range of motion is, sir, from right side, it's 20 to complete flexion of around 120 degrees. And on left side is 30 degree to complete flexion, sir. There is complete
On the
flexion.
knee range of motions.
Sir, knee range of motion. Yes, sir.
Okay, okay. You told about knee.
Yes, sir.
Essentially, it's one thing,
Yes, sir.
and then
Further flexion is possible. Yes, sir.
Major,
Range.
major. What are the measurements? You can tell.
Sir, on measurement, Ziffy sternum to middle malleolus bilaterally 61 centimeter. Ziffy sternum to middle malleolus bilaterally 61 centimeter. Sir, anterior superior iliac spine to patella is bilaterally 26 centimeter, and patella to middle malleolus bilaterally is 25 centimeters, sir.
There is no segmental shortening. Segmental lengths are equal.
Yes, sir, they are equal. Segmental lengths are equal.
So there is no shortening.
Sir, there is proportionately there is shortening of femur. Because femur is equal to TV.
Bilaterally, if you compare, both are equal.
Both are equal, sir.
Both are
Yes. Yes, sir. Bilateral.
Sir, you want to add anything, sir?
Can you just bend the knee both side to demonstrate the it's
Ellis test. Demonstrate Ellis test.
keep the foot down. Then keep the knee the same level as well as the this posture. Do you think that the level of the knee is equal on both sides or one is at a higher level?
Level is equal.
Sir, level is equal, sir. Both are equal.
From our side, it looks that the left finger will be at a higher.
Sir, it might be just because of the camera angle, but it is, they are equal here.
Yeah, from this now I agree that both are the same level. Fine.
Both are equal. Okay. Proceed.
Sir, clinically femorotibial angle measured on right side is 25 degree and left side is around 34 degrees, sir. Yes, sir.
Demonstrate measurement of femorotibial angle.
Sir, we locate the patella in the center of patella and we locate the ASIS. So we draw a straight line from ASIS to patella. And the another line we draw from the tibial tuberosity to patella and we measure the angle, sir.
Okay.
Q angle.
So it is higher on one side, right?
Yes, sir.
Which side it is higher?
Left side, sir.
Left side deformity is higher.
Higher.
What else you measure to confirm the
Sir,
deformity?
Intercondylar distance and intermalleolar distance. Here the intercondylar distance is 15 centimeter and intermalleolar distance is 3 centimeter.
What is the normal value of intercondylar distance
Sir, intercondylar distance should be less than 6 centimeter.
and intermalleolar distance?
Sir, 0 degrees, sir.
0 degree?
8 degrees.
It is in centimeters.
8 centimeter.
Should be less than 8. Okay. So what is your probable diagnosis based on this examination you have done?
Sir,
So first, what do you think? Probable diagnosis? Is it the patient is not, this child is normal? Is it this child is syndromic? What do you think in this case?
Sir, the patient is probably my first diagnosis will be due to
I'm not
metabolic.
asking diagnosis.
Hmm.
See, according to his age,
Hmm.
the height is okay or
Short, sir. That
short, sir.
side,
So
it looks syndromic.
it looks syndromic.
Also
So
there
first
is-
we should
Yes.
say if this patient is of normal height according to his age category and with this bowing deformity, then patient may not be syndromic. But in this case, multiple, you can say elbows are involved, even hips are involved, even the knees are involved. So it doesn't come under, and height is short, doesn't come under.
Syndromic.
Okay.
So what is your probable diagnosis again?
Sir, my probable diagnosis is a 9-year-old male with bilateral genuvarum deformity, probably secondary to metabolic causes or skeletal dysplasia or hereditary.
You were telling that you were feeling some bony
Sir,
prominences on the
there is a possibility of hereditary tumors.
hereditary tumors.
Sir.
What hereditary tumors?
Sir, it could be exostosis, sir, multiple hereditary exostosis
Multiple
because
hereditary
multiple
exostosis.
lesion of swellings are present.
So yes, sir.
Multiple aplasia.
Sorry.
Yes, sir, proceed.
Proceed. Proceed.
So,
Okay. So this is what you would like to do next.
sir,
How will you confirm that? So you have given some
Good history.
one is syndromic.
yes, sir.
Probably.
Yes. You can see. How will you confirm now your
Sir,
diagnosis?
first we'd like to do some blood investigations.
Okay.
Sir,
So what are the blood investigations?
sir, keeping in mind the metabolic profile, we should do complete blood count, serum calcium, serum phosphorus, parathyroid hormone, alkaline phosphatase level,
Vitamin D. What about vitamin D?
vitamin D, and
So it's the most common cause of deformity,
is
especially in developing countries. It's a rickets,
yes,
vitamin D deficiency. Okay. Any radiological investigation?
yes, sir. Radiologically, first we'd like to do the AP and lateral radiograph of the knee joint and scanograms at bilateral level.
Excellent. X-rays.
दिखा दो भैया. Sorry, sir. Sir, our first X-rays are going to be of knee joint, and then we can see further. Sir, in this case, we would like to get hip joint and spine X-rays as well, sir.
Slide show. आगे
आगे आगे.
Screen sharing of part.
We are not able to stay sequence.
So, sir, is X-ray visible to you?
No. Need to change the window. Share the screen.
Is screen visible, sir?
Yes, screen is visible, but there is no picture in that.
Sir, describe the X-rays.
Oh, they stop for sharing the X-ray.
Describe the X.
These So these are the digital radiograph of showing the anteroposterior and lateral views of bilateral knee joint with distal tibia and distal femur and proximal tibia. Sir, in the knee joint, we can see bilateral varus deformity on the anteroposterior radiograph. Sir, there is metaphyseal broadening, and so the physis looks irregular. So there is physis looks abnormal. It's,
Comment on the epiphysis also in this case.
sir,
Epiphysis and metaphyseal area. Are they looking normal?
no, sir, they are abnormal. Epiphysis is looks degenerated with multiple calcification.
Multiple calcium. So epiphysis, as per his age, 10 years, they are not fully grown up. And you see broadening and widening. What about those bony prominences you were feeling? You don't see any bony prominences there.
No, sir.
Physial line. Yes,
Physial
physial line is not
not
appearing.
clear.
So any sign of metabolic cause here?
Sir, there is just broadening of metaphysis.
So metaphysis are broadened
Yes.
and there is some fraying of metaphysis
Metaphysis.
edges.
Yes.
Okay, baki physis looks dysmorphic, irregular. And would you like to get something else?
So
Comment
the
on this
cortices appear thick. Sir, the bilateral scanogram, there is obvious bilateral genovarum deformity.
hips. Are hip normal?
Sir, there is bilateral coxa vera deformity.
Okay. What is this medial proximal tibial bar which is there? You see, there is some specialized area on the medial side. What it is?
Sir, it occurs in diseases such as Blount's disease, sir, where the physis droops down and gradually a bar
Can
is formed.
also be because of continuous medial loading of
Yes.
the proximal tibia.
Yes, sir.
Yes, the kid is walking since last 7-8 years with
Yes.
this gait, and it is because of the continuous pressure over this area.
Yes.
What would you like to do?
Can we have the lateral views, true lateral view of the femur?
Lateral views, spine,
Lateral view of the femur.
lateral view of femur. Yes. Also speak.
Full length, the lateral view of the femur will be more. Because there may be bowing of the femur.
Sir, we don't have lateral view of femur. This is the view we have. Zoom out.
Okay. So there is people calcification, the epiphysis and metaphysis.
Lateral.
Sir, can you have some explain?
Zoom कर इसको. Stippled calcification देखना lateral. Yes, there are stippled calcification in the epiphyseal metaphyseal area. Prominently, they are more in the epiphyseals. So it can be epiphyseal metaphyseal skeletal dysplasia.
Yes, sir.
Here pelvic X-rays. Comment on pelvic X-rays.
The bilateral hip joint, there is coxa vera deformity. Head has the femoral head has not appeared till now.
Okay. Left his hip appearing
Subluxated.
significantly widened. Left acetabular socket is
So there is joint space widening on the left side.
actually it is present on the both side. Bilaterally it is there, but on left it is more. Nine X-rays. Zoom on the lateral. Is he having scoliosis? You have examined scoliosis? Adam test, demonstrate Adam test. Okay. Doesn't have any scoliosis. Okay. X-ray is fine.
Any other sibling in the family have got such deformity?
Pardon, sir? We didn't hear you.
Any other sibling have got such deformities in their family?
So no, sir, no history of any deformity in the family of limbs.
No
See the
consent.
child of the family or their other children?
So he's the only, yes, sir, only kid with deformity in the family, although the history is given by his uncle.
Any other
Parent.
test you would like to get it done?
Sir, after the blood investigation and radiological investigations, we can get molecular tests done
Yes.
for this patient.
Molecular.
Sir, if we are suspecting skeletal dysplasia, then there are various
The
mutations.
collagen developmental
Disorders. Yes.
Collagen X is usually not malformed in those cases. Okay, what is the treatment? How would you treat it?
Sir, after all the investigations for this age of patient, sir, we would like to do hemiepiphysiodesis, sir.
In this case, tibia, femur, or both?
Sir, on the femur sides.
Why now?
Sir, because our deformity is on the femur.
Okay. So primarily pathology is in the femur.
Yes, sir.
Okay.
What implant?
What implant you will use?
Sir, we can use figure of 8 plate or staples.
Laterally or
Middly, laterally or middly?
Sir, we'll do laterally, sir.
So which one is better? Is it figure of 8 plate or is it staple is better? Which one is better?
I don't know.
Okay. Both can be used, but figure of 8 plate is better than staples. Okay. So when should you take, suppose you have gone for a hemiepiphysiodesis, when should you take out this implant?
Sir, we should have regular follow-up of the patient. And once we have seen the deformity has significantly improved, we can take it out before skeletal maturity only.
But you look for
Sir, we'll look for physis closure, sir.
physis closer?
We should remove it before closure.
Oh dear. Progression.
How will you know that
Sir,
Is it
we'll-
getting improved or is it getting worse?
Sir, we'll calculate the varus deformity angle in the patient.
How do you calculate then radiologically?
Sir, radiologically, we can do it on the bilateral scanogram, and clinically we can
So what are
calculate the
the-
intercondylar distance also.
What are the angles you can measure or on your X-ray that this deformity is increasing, decreasing? What are those angles?
Sir,
Have you heard about the lateral distal femoral
distal
angle,
femoral angle and
middle proximal
tibial
angle?
sir.
Or can you divide the mechanical axis? Where does the mechanical axis pass normally?
Sir, normally passes from the head of the femur
Yeah.
to the 62.8% of the lateral to the knee joint, and then to the central.
Knee joint. Lateral to knee joint.
To the for this point. normally from the intercondylar distance, intercondylar notch,
Notch.
and down to the midpoint of ankle.
Okay.
So, most reliable and quickest test after having your hemiepiphyseal test is done
Yes, sir.
clinically, because in such a short kid, if you get repeated X-rays done, this is actually not good.
Yes, sir.
You can get it done for implant positioning as well, but intercondylar distance measurement, it
Yes.
is the very easy, very clinical friendly test, can be done totally non-invasively. If kid is feeling fine and having varus corrected good enough, then you can remove those staplers if needed,
Yes, sir.
but they are to be removed. If you don't remove them, one thing, they can break, or they can
Opposite.
totally opposite deformity can occur.
Yes, sir. Yes, sir.
What should you do, under correction or over correction?
Overcorrection.
Over correction, so you will make him walk in valgus.
Sir, because the child is growing, so later it will be get corrected again.
It is not overcorrection. It is mildly over the normal.
Normal.
Don't say overcorrection. Overcorrection means something horrible. So depending upon the how much epiphyseal growth is the patient has, so that will determine your whether you suppose you are going for a hemiepiphyseal disease in the 15-year case, a boy who is going to be skeletally mature in 17 years. So will you like to go overcorrection? No.
Sir.
Then a normal. If you are going for a, like in this case, 10 years, 9-year or 10-year-old male, and he has a, you can say, skeletal growth period of at least 8 or 9. Usually in boys we say it's a 15 to 17 year skeletal maturity. So in those cases, you can go for a mild overcorrection. Okay. And what should be your follow-up protocol once you have achieved this correction? These deformities are known to recur. So what you always should, parental counseling in addition to your surgical and your nutritional treatment.
Yes.
Of course, in this syndromic patients, we must rule out other congenital anomalies, whether these patients have multiple problems. There may be another, you can say, problem with the heart, or there is a kidney. So at least we must screen these patients.
Yes, sir.
Okay.
Sir, would you like to add anything, sir? Good presentation.
Thank you, sir.
Okay, thank you, sir. Thank you so much, sir.
Thank you, sir. Thank you.
Okay. So thanks, Dr. Professor Govardhan.
Thank you, sir.
After so many years, we have seen a face of each other, or at least on the screen, not physically. So thank you, sir, for
Thank
giving you can say, nice opportunity to learn. It's not, I think I always say to my, you can say, students, it's not the learning of students, it is the learning of the faculty also. It is the learning of the senior residents also. So such type of courses, I think we should conduct more frequently so that we can get benefit of each other's knowledge and for a better, you can say, medical education. Thank you, sir. Thanks a lot.
Thanks to the city because we thank you so much for this. Thank you so much.
Okay.
Camera.